I'm Gia.
And I'm Jake.
Today we'll be discussing Guillain-Barré syndrome, or GBS. We'll go over what GBS is, how it progresses, and most importantly, the role of speech-language pathologists in evaluating and treating individuals with that disorder.
So, what is Guillain-Barré syndrome, or GBS? Well, it's an acute autoimmune disorder that affects the peripheral nervous system. In GBS, the body's immune system mistakenly attacks the myelin sheath and sometimes the axons of peripheral nerves. This disrupts nerve signaling and leads to rapidly progressive symmetrical muscle weakness. GBS is often triggered by respiratory or gastrointestinal infection and is considered a medical emergency because the weakness can spread to the respiratory muscles and autonomic nervous system.
Although GBS can occur at any age, about 90 to 95% of cases occur in adults, with incidence increasing after the age of 50. Children account for only about 5 to 10% of cases, but generally have an excellent prognosis and recover within 6 to 12 months with appropriate intervention.
Disease pathophysiology. The pathophysiology of GBS begins with a respiratory or gastrointestinal infection, which triggers an abnormal immune response. Instead of only attacking the infection, the immune system begins attacking peripheral nerve myelin, and in some cases the axon themselves. This damage slows or blocks nerve conduction, producing characteristic ascending muscle weakness that starts in the legs and moves upwards. As the disease progresses, bulbar muscles and respiratory muscles may become involved, leading to dysphagia, dysarthria, and potentially respiratory failure. These complications are especially important for speech-language pathologists because they directly affect swallowing and communication.
GBS disease progression. GBS typically follows 4 stages. During the initial phase, which occurs over the first 1 to 2 weeks, patients develop tingling, numbness, and symmetrical weakness that usually begins in their legs.
During the progressive phase, symptoms worsen and may include dysphagia, speech changes, respiratory weakness requiring mechanical ventilation, and autonomic dysfunction.
Next is the plateau phase, where symptoms stabilize for several days or weeks without any further decline.
Recovery usually begins about 2 to 4 weeks after the plateau and generally occurs in the reverse order of symptom onset. Most patients recover within 6 to 12 months, although recovery may continue for up to 2 years. Fortunately, about 70 to 80% of patients recover with little or no long-term disability.
The clinical presentation of GBS typically includes ascending symmetrical weakness, decreased or absent reflexes, tingling or numbness, facial and bulbar weakness, dysphagia, weak cough, poor secretion management, respiratory muscle weakness, and autonomic dysfunction. Because cranial nerves are frequently affected, patients often experience swallowing and communication difficulties, making early involvement of speech-language pathology very important.
GBS and SLPs. SLPs play an important role in managing the functional effects of GBS. Swallowing problems may include a weak cough, reduced airway protection, and difficulty managing secretions, all of which increase aspiration risk.
Speech and voice may also be affected due to flaccid dysarthria, reduced breath support, weak vocal intensity, breathy voice quality, and hypernasality. Some patients who are intubated or experience severe fatigue may temporarily require augmentative and alternative communication, or AAC.
Although cognition is generally intact in GBS, patients in the ICU may experience temporary cognitive communication changes related to delirium, medications, fatigue, or hypoxia.
Clinical reasoning. When working with patients diagnosed with GBS, an SLP can predict likely impairments based on the disease process.
For swallowing, we expect delayed swallow initiation, reduced tongue strength, decreased laryngeal elevation, and increased aspiration risk. For speech and voice, we often see flaccid dysarthria, hypernasality, reduced respiratory support, and weak vocal quality.
It's also important to consider differential diagnoses such as brainstem stroke, MG, ALS, and critical illness polyneuropathy, since these conditions can present with similar symptoms.
Assessment and treatment. Assessment begins with the clinical swallow evaluation and oral mech exam. If indicated, instrumental assessments such as an MBSS or FEES are used to evaluate swallowing safety. Motor, speech, and voice assessments are also important, along with speaking valve evaluations for patients with tracheostomies.
Medical treatment focuses on stopping the autoimmune process through IVIG or plasma exchange while providing respiratory support as needed. From the SLP perspective, treatment may include dysphagia therapy, speaking valve training, motor speech therapy, and AAC when appropriate, and education for both patients and caregivers.
Quality of life and key takeaways. GBS can cause a sudden loss of mobility, communication, and ability to eat safely, which can greatly impact a patient's independence and quality of life. SLPs help improve quality of life by restoring communication, promoting safe swallowing, educating patients and families, and supporting participation in everyday activities.
The key points to remember are that GBS is an acute autoimmune disorder affecting the peripheral nervous system. Bulbar weakness places patients at high risk for dysphagia and communication impairments. Respiratory decline may require mechanical ventilation or tracheostomy, and early SLP intervention plays a vital role in improving patient outcomes.
Thank you, and I hope you learned a lot. And here are our references.